Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Burjor and Andrew. How are you guys doing today?
And thanks, Dennis.
Amazing. Thanks for having us.
Hey, I really appreciate you jumping on. We got two facial experts, and guess what today's topic is? Facial trauma. So, Andrew, since this is your very first time on the podcast, would you mind just doing a quick introduction of yourself?
Yeah. So my name's Andrew. I'm the program director of the Oral and Maxillofacial Surgery Residency at WOMAC. And I did a fellowship in craniomaxillofacial trauma and reconstruction. Being here with you guys, talking about the translation of what we do with these higher level facial injuries, focusing on pre-hospital care, austere care, and prolonged field care topics is kind of a passion of mine. I spend a lot of my time working and training people who deal with these environments. So happy to go through some stuff today. And if any of the listeners are curious or want to reach out to me afterward, please do so. I feel like those little connections that we make in our world sometimes are some of the best things that can happen. So if you're a listener, I'm here to support you as well.
Hey, awesome. Burjor, would you mind just doing a quick recap?
Yeah, sure. Hi, my name is Burjor Langdana. And like Andrew, my passion is teaching facial trauma and emergency dentistry in a pre-hospital environment. I did masters in maxillofacial surgery in India. And that's what I tell my students is that's where I learned how to wire jaws from and everything to do with wiring because we couldn't afford anything else. And then when I went to UK, I did my fellowships in maxillofacial surgery and learned everything that was to do with bone plating. And finally, then when I went to Malawi, Africa, there I again learned how to work in an austere environment and use things like K-wire, etc., to reconstruct jaws post-cancer. And we've been discussing this with Andrew and Dennis, and my question to both of them was that why isn't jaw wiring taught often to medics and trauma surgeons in the field? Because it is such a vital component of pre-hospital facial trauma management. And when we used to teach medics from Myanmar, that is the one thing that they were desperately wanting to know. And the Ukrainian medics and trauma surgeons also desperately want to know how to manage and do jaw wiring and how to give regional anesthesia. So that's the one question I want to start off this podcast with, is asking that question to Andrew and Dennis.
Okay, I guess Burjor is running this, but why as a medic did I not learn it? My guess is it was GWAT, and I'm going to have a helicopter land on me here in like 15 minutes or less. So we didn't have time for that. And so it's all about hemorrhage control and pain control and wound care and things like that. So I think that just kind of got pushed down on the priority list.
And I would say we, over the last 5 years, we've made a concerted effort for everybody who enters our sphere to teach those two particular skills, because I agree with you. I think any medic can do both of those quite easily. And there's been some new innovations and tools that allow that to make it even easier with a little bit of review and hands-on practice. So if you're somebody who is out there listening to this and taking care of patients in those environments, a little bit of brief training. And as we start to cycle through topics, one thing I really want to emphasize is most oral surgeons, dentists, anybody who does facial anesthesia, a lot of it is synonymous with the same things you need to do in trauma. Go and spend half a day or a day with them doing some refresher training. And, dentists and surgeons, we see patients constantly practicing all these things in real life. So getting a little bit of hands-on experience to get your comfort level up will translate to having those skills on the battlefield. And breaking down wiring jaws, which is so critical from jaw fractures, accidents, blast injuries, gunshots, and more aggressive shrapnel type injuries, and all the patterns that we're seeing emerge currently, is such a critical skill. I totally agree. And figuring out how to do it with limited resources. You can use almost anything to do it if you can fit it around it, as you well know, Burjor. So a little bit of familiarity of the goals of you're trying to accomplish, and then you can jury rig it and figure out what you do with your supplies. So I totally agree. And, if I think it should percolate more into all the training stuff that everybody is doing because it's such a reality of the battlefield.
I guess what I was hoping we would jump into is like the actual facial trauma, penetrating injuries. Like you see the injuries coming out of Ukraine. It's all coming from top down, either by drone or artillery or mortar. And so you get a lot of facial trauma, neck trauma, upper chest trauma, and just a lot of penetrating injuries that way. And I gotta be honest, the face is really scary when it gets hit with high speed metal. So when it comes, let's just start off just basic march things, right? Hemorrhage control is the first thing we got to tackle. Like where are the major vessels in the face? How do I stop that bleeding initially so I can just at least get a look at what's going on?
Yeah, that's a good question. The face is one of the most vascular parts of our body. It makes it great for our surgeries and reconstructions because they have a really high % chance of success. But conversely, it can make it quite difficult in the setting of trauma. With these shrapnel injuries, and I would say as you're doing just your initial look in hemorrhage control, the penetrating wounds, even gunshots a little bit bigger, they tend to be fairly small. Trying to get packing or whatever you can deeply inside of it with pressure, and you can do that as you work down, kind of cleaning things up, packing little shrapnel sites to get a better idea of what's going on. Most of the time, those shrapnel pieces or injuries are going to be deep enough where you're probably not going to chase it in a field environment. Imagine your comfort level will have to be pretty high. There tends to be a number of different arteries and veins in the face, the facial artery and vein, the tributaries, but most of them kind of like from the inferior border of the mandible up tend to be about 1 to 2 millimeters in size. The retromandibular vein kind of behind the mandible is usually about 3 millimeters or so. Tends to bleed a lot when hit. Ask me, I've done it in surgery. But really, all of those things we will commonly ligate during our facial approaches, so they're not too worrisome. And a lot of times, pressure can kind of tamponade them off. Really, you have to get concerned with the carotid, the common carotid, and the bifurcation. But in that kind of initial shrapnel, they're peppered, and you're trying to get some damage control. As we all know, neck tourniquets don't work so well, so really time and pressure like your other injuries. And I would say kind of individually packing the sites that are bleeding as much with whatever you have. I imagine most people have combat gauze, quick clot, or something like that, or additional hemostatic agents is kind of your best friend. So at the end of an exploration where they have, a number of different penetrating things, they might have a bunch of little strings of gauze poking out from everywhere and, just leaving those for a good period of time. Additionally, with pressure on top with a hemostat or an instrument, if you can, if just packing it doesn't really help decrease it. From surgery, most of the times when I clip or, when I see a vessel hit in the head or neck, that's not the carotid and is something a little bit medium caliber. Most of the time, they tend to vasospasm off after somewhere between like 10 and 20 minutes. So really, if you can get past that kind of 20-minute mark, and that's what I do in surgery. I have a bad bleed. I'll pack it right where it is, hold it aggressively, look at the clock and give myself time. So packing it good and using that pressure should allow you to progress through your algorithm. And then, you're not really probably going to go past that in the field environment. So just leaving them packed, we could talk more about like length of time and other considerations, I think would be the good first step. Does that kind of make sense? Anything to dig into there or further questions?
So there's like when I'm thinking of a stopgap, like, like a bad leg bleed, you're putting pressure on the femoral, right? From external pressure on the femoral just to stop that bleed so I can look inside and get packing directly into the wound without it just continuing to gush out. Is there any stopgaps in the face? Like I've heard a lot of people talk, just put pressure behind the mandible and that'll stop like the top part of their face from bleeding, and then you can pack individually. Having seen pictures of the face and the vascular, it doesn't seem like that would be the right thing. But
that's a good question. Yeah, I don't think so, because even if you were able to, it'd be incredibly hard to exert enough pressure on any of the carotid or the individual major tributaries that come off quickly to do that, because it's all going to be soft structure. And even with you pushing really hard, you're not going to be able to do that. if you have enough knowledge, and for example, the facial artery and vein kind of run up underneath the mandible and then kind of cross over the inferior border as they move anteriorly. If you're able to push against the mandible anywhere and see a decrease in bleeding, I would say go for it. Because maybe it's an artery or vein a little bit distal to that. And I think what you're mentioning is probably the retromandibular vein. And if it's particularly hit, which is kind of like if you're picturing it as a listener around the angle of the mandible up to the ear, then I would say good. You're not hurting anything to try that. It probably won't work. And there's so much cross collateral circulation. A lot of times, if you have a reasonable injury on one side, even if you were able to accomplish that, it'll come from the other side enough where it's still bleeding. So I would say you're not going to hurt stuff, but it's a lot less effective than like a limb trauma.
Yeah. And it might not be,
Yeah, sorry.
I was going to say it's, might not be harmful, but if it's wasting time, then it is harmful.
Yeah, a fair point.
Yeah, so basically, sorry, with the injury, it's just essentially drone attack is like the most common thing happening nowadays. And the death rate from isolated facial injuries at present in Ukraine from drone attack is nearly 39%. And the Vietnam Wars, it was like 20 to 25%. So a huge leap in that situation. So now what are we trying to teach them is that, okay, so where the guys got hurt is usually where he's been hit with the drone. So the last thing now we want to do is to get more people hurt trying to save this particular guy. So we tell them, forget about everything. The first thing is to get rid of any dodgy ordnance which is there on him, because they tend to explode because they are like badly damaged. So they explode and then they injure everyone else. So they get rid of all their possible existing ordnance stuck to that guy, literally grab him by the collar and shift him to a tree line or a safe zone. And still, you haven't even started your primary resuscitation at that time. The next thing is now they're in a location where they shouldn't be. So they were supposed to be in the field, but they're not in the field. They're in another location. So and everyone there is so close to each other. The Ukrainians, Russians, everyone is just very, very close to each other. So when you change your location, your colleagues or your friends or your batchmates don't know you're in that location. So then they will think you're the enemy and try to get at you. So again, the primary resuscitation is not started. The next thing they do is to go on comms and tell their bosses where their location has shifted to, so they don't injure them. Next thing you've got to remember, these guys are going to be stuck there. It won't be like half an hour, an hour. The R1 is going to be stuck there for at least 2 to 3 hours, if not more. So then they start saying what they can do. So what we decided now is to stratify the stabilization. So we converted into emergency stabilization, primary stabilization, intermediate stabilization, and finally where Andrew's domain is like reconstruction. So in primary stabilization is essentially bandaging. And as we were all discussing, is getting the pressure where it is needed. Now, what can they possibly do when they're stuck in a tree line with the R1, agreed R1, very experienced combat medic, below a tree line just by themselves with minimal equipment? Of course, they have pressure. So let us look at where the bleeding could likely come from. And it's hard. Andrew's absolutely right. It's hard to put pressure where the bleeding is coming from. So if you look at the scalp, that's easy, that you can put pressure there. The hard one is the hidden pressures or the occult bleeding, where you cannot see where the bleeding is coming from. And in that, there is a couple of them which are urgent and one which is not so urgent. The urgent one is, of course, as we probably know, is the mid-face bleeding, which is taking place from behind the maxilla. So basically, if we have injuries, and I'll share that with Andrew, whereby the lower half of the maxilla is blown off, or a part of the maxilla is blown off, then you have bleeding coming from behind the maxilla. Now, our soft guys did this before, and now it's an established technique, which is known as the mid-face splinting technique. So essentially, we put an inflatable catheter in the nose, a bite block in the mouth, and a cervical collar or cervical support on the neck. So therefore, when you inflate the inflatable catheter in the nose, it creates a pressure to reduce the bleeding in a site which is impossible otherwise to reach. So of course, it works sometimes, it doesn't work sometimes. But if you want it to work, you have to put 2 inflatable catheters. You can't put one. And it all has to work properly as a single stage. Now, when you inflate that, it pushes the maxilla down. To prevent the maxilla from drifting further down, you have your bite block, which is blocking it. Then, of course, your mandible could also be blown up. So prevent the mandible from going down, you have a C-spine collar to prevent the mandible from shifting down. So that is known as a mid-face splinting. We use what is known as an epistat. Each one costs around 40 to 50 pounds. They cannot afford it. So what they use is essentially what we are all familiar with, which is Foley's catheter and an anterior nasal pack. And that is what we are familiar with. So what have we changed? So we says, yes, Foley's catheter, you have to use a 30 ml Foley's catheter. Using a 10 ml just doesn't work. It just gets pulled out. So you have to use either 30 ml one, 14 to 16 gauge. You shove it in, you inflate it with liquid, not fluid, not air. And then for an anterior nasal pack, we are suggesting using a hemostatic gauze like Celox. So the anterior nasal pack is a hemostatic gauze, which can work really well, okay, or cannot. And if you don't have that, it is just a normal pressure pack. So agreed, some people say it doesn't work. Some says it's work, but frankly, you don't have much of a choice. That's all you have to reach that particular area. Then if you work your way down, of course, posterior pharyngeal bleeds are really hard to get. And in that area, in the oropharyngeal area, again, if you want to put pressure, you have to do a surgical airway so that you can put pressure in that area, or the patient will anyway die. So that's the best you can possibly do. Then the one which is next most urgent would be in the neck. And as Andrew said, it's a shrapnel. Now, the shrapnel going through the one rule shrapnel follows is that it follows no rule. It goes wherever it wants to go, destroys wherever it wants to destroy, and it can go in the weirdest possible places with the smallest possible openings. So if you have a small opening in the neck, or you think there's a bleeding coming out through a small opening, you literally cannot get to it. So instead of doing nothing, as Andrew said, you can push in a hemostatic gauze and trying to get there, or something which they use right from the Iran-Iraq wars, South Africa, and now in Ukraine. In my class, more than 3/4 of the class have done it routinely, is by using Foley's catheters. They shove a Foley's catheter in down the tract as deep as it goes, and they fill it till it gets pressure with liquid. And that varies between 5 to 20 ml of fluid. It's got so common that we've introduced a full module whereby they do it on the lateral chest wall of a pig, how to put Foley's catheters in, and how to use it, and how to problem solve. So if you put a Foley's catheter in, you put pressure and the bleeding stops, fine. If the bleeding does not stop, how do we get around that particular solution? And how it's essentially the balloon is going in the wrong place. That is why the bleeding is not stopping. The pressure is not going where it's supposed to go. So we teach them what to do to problem solve that particular area. And the last one, which is a slow one, which you could easily miss out and does not happen often, is going below the lower border of the mandible when you could possibly have, let's say, a lingual artery bleed. And that bleed can go on quietly into the facial spaces, and you won't be able to see it. What you will be able to see is that the patient getting progressively difficulty in breathing, and that should trick you off that something wrong is happening because you cannot see it. You will see the tongue getting bluish and swollen, floor of the mouth getting lifted up, and that should point out there is something happening there. So Shuka in Iraq also used Foley's catheters for this technique. Also, it worked occasionally because there's no pressure to push it against, and very often did not work. And these should be pushed up the priority list. It cannot kill the patient. It will obstruct the airway, but you put a surgical airway to get around that. So till you've done that, it will bleed. But the bleeding, as Andrew said, the diameter is not big enough to kill the patient rapidly. So it'll progressively go on, and you just have to stabilize this patient when it goes on in that particular way. And of course, junctional pressure dressings, but they're a pain because they keep slipping, they keep moving, they last for only that long. And for obvious reasons, the patients are not exactly cooperative because they're in a lot of pain and they tend to move around a lot. So we do advise them to use Celox pressures in that area to do it. And they said, yes, it works and doesn't work. So we try to figure it out why in some patients, when they definitely saw an open bleed and put Celox or hemostatic gauze in, good quality one, why did it not work? Problem was that in Celox, you have to use the entire bandage. So of course, you get the plug which forms first, positive, negative forms a plug. Then the plug get reinforced when the fluid goes to the rest of the pack, and the rest of the pack adheres to the soft tissues, reinforcing that clot. But because it is so precious, they put the Celox at the start, and then they cut it off and they put a normal pack of gauze on top because they want to save the Celox gauze for future use. And that is sometimes a problem why it doesn't seem to work so well.
Yeah. No, that makes sense. Yeah, that Celox, once just the wetness of blood gets into it, that kicks off its reaction, and that's what makes it essentially like a big mucus plug, and that's what helps get you your pressure. So you got to use enough of it so that it can have its reaction.
Especially
Using
Celox Rapid is phenomenal. Yeah, it is brilliant.
Using the Foley catheter, so like we have definitely used Foley catheters. They're not super easy to push. Do you use like a stylet or something to help guide it into the tract?
Okay, so basically, if it is one person, he takes a Foley's catheter 18 to 20, one click on the artery forceps, puts it as deep as possible, plates it with 5 ml of fluid, takes the artery forceps out, and then pushes in another 5 to 15 ml of fluid till it feels resistance and the bleeding stops, and then stitches it up, ties the end, and holds it in place. If there are two people, then the first person, the main operating surgeon, uses his finger, pushes it in, holds it in place, then his colleague inflates it with 5 ml of fluid, you take your finger out, then you put it full 10 to 15 ml to 20 ml of fluid in. However, if it is shallow, what we suggest is you put the Foley's catheter in, and then you have to put your stitch first to hook it in, and then fill it up with fluid. Otherwise, it just bounces straight out. So that is what you do it if it is shallow. If you pushed it in, and if the bleeding continues, but it's coming out of the lumen of the Foley's catheter, that means the bleeding is more distal to the Foley's catheter, in which case you could either put more fluid in if you can, or deflate it, take fluid out, push it in deeper, and then refill it up again. That's one way to do it. If the bleeding, it continues but is coming from outside, nothing is clear cut and you can't exactly see, but theoretically, if it's coming just flooding out, then the bleeding is probably coming on top of the balloon in this case, in which case you could put a second Foley's catheter in and do the same thing. Now, the 2 points to that is that, do you guys know what a Cook's catheter is? It is used by obs and gynae people. It's one catheter with 2 balloons. Yeah, it is fantastic. So that is what we showed it to them, is why instead of using a Foley's catheter, don't you try a Cook's catheter? Because one similar to Foley's catheter, but it's got 2 balloons. So balloon down and balloon up. So you could use that. Problem is access. So they haven't, because in Ukraine, you only can get certain things. You cannot get everything. So that's one thing. Secondly, of course, the main complication is it puts pressure on the carotids. It puts pressures on the carotids, and even a young, fit person could have problems or stroke after that. It is an acceptable complication when you're trying to stop a bleeding in an austere environment where otherwise the patient is going to die. So that is the things which we are working around to further improve their skill in Foley's catheter, which is already enormous. They're highly experienced in it. Actually, the shallow bit we introduced because Dave had this problem, And they've said it bounces off or the balloon is too superficial. And when we put a stitch in, the stitch goes through the whole balloon and we have to repeat the whole thing again. Yeah.
I mean, some of these shrapnel holes are pretty small, and they can still be devastating. Will you open up the wound to get room to then inflate the catheter or to push in the catheter?
Or put your finger in. Absolutely. Andrew, what do you think?
I love it. I love hearing the translation of how to make this more simple. The idea of getting the Foley there, and I'll start with kind of some of the more nuanced things you brought up because so yeah, and particularly in the neck and following these tracks, yeah, if you can get a Foley or something to get better pressure there, even if you're not directly on the vessel, but you create a space to kind of keep it. If that pressure gets up high enough, you're going to probably slow that down substantially, if not, hold it in place. Like you mentioned, I think really thinking about a surgical airway early because, when you have an expanding neck hematoma, you're just really worried about the pressure on the airway. But if you already have that controlled, great, even better. Same thing as you discussed with like floor mouth hematomas. I think that is a really slick thing that if you can make it work, it would help. And I also love to hear about, I hadn't heard the mid-phase stabilization strategy. It's I'll put Foleys in there sometimes with really bad posterior nasal bleeds from Woodruff's plexus as opposed to the anterior part. That area, I would say probably if the injuries are closer to the midline, it would be more responsive to the pressure there like you're describing. There's a lot of vascularity, the descending palatine arteries that are a little bit side that kind of come down from the skull base. And then right behind the maxilla is this kind of nebulous ethereal plexus called the pterygoid plexus of veins. And when those are hit and you're talking skull base as well as some major arteries, like even surgically, that's like a pack and hope for me and get interventional radiology. So, putting those Foleys in there, I think is a great idea and, hoping for the best. But probably if you don't see success with that, it's probably just a little bit off of where you're able to get it and, combine that with pack and, hope for the best. But I think that's a great idea of trying to get a Foley in because like you said, it's a great way to put pressure in a really difficult to reach area.
I think the one nuance which I forgot to say was when you put a Foley's or an epistat. Epistat is fantastic if you have it. If you don't, because it's designed for it, specifically designed for this thing. But if you put a Foley's or an epistat, you inflate it with 30 ml, and then you pull, there's a traction, you pull the traction upwards and forwards. So you're reducing the bone to a certain extent. And then you're putting your anterior nasopac. In the case of epistat, you're blowing the anterior balloon, but there's a counter pressure from the block below. So this partial reduction helps further reducing the bleeding. Now, we tried it out on organic material, and it works in the bottom line, like leaf out one level, where you just have a mobile palate and teeth, and it's floating. You do get bleeding, but not as much, and it's easy to do, reduce and fix. Leaf out or the middle level or the leaf out 2, where you have your mobile palate, teeth, and nose. That is the one it works best in because your fracture level goes to the middle part of the pterygoid plates at the back. It is movable by traction. It does move forwards by traction. It does hold there. Only time is sometimes because the cheekbones are going down, it blocks it when it's locked behind this zygomatic process down here. It sometimes gets locked behind it, and you've got to tilt it down a little bit before pulling it back up to get over that. And that it works best there. The one place where it does not work very well is the high-level fractures because you have a bleeding from the internal as well as the external carotid arteries. And because of the impaction of the fracture fragment, there is no mobility or very little mobility. So even when you pull traction, it doesn't actually work very well there. And the patients do tend to bleed, but they are generally in a bad way anyways. And because your options are so limited, that's about all you can do.
Yeah, those are good points. Oh, and to your point about the stroke and carotid, a lot of times I really like hanging out with vascular surgery and doing carotid endarterectomies where you expose the carotid, you tie it off, you cut out plaques because there's no better training for carotid injuries than purposely cutting them open. But the stroke risk and everything, I think in relatively young, healthy people, we'll tie that off and you can, it's an absolute worst case for us about, why get a carotid intentionally. But I think one thing that you might see if you create pressure in that area and it pushes on it is more of a vasovagal response too. Like a strong. So if you see their heart rate plummet or they're clinically suddenly start to change, you could be compressing the carotid with an injury around there and clamping it with the Foley to create a little space. So just be aware that I think that would be the most likely thing that you would see pretty quickly clinically, and then you may have to reverse course, or then you'd be in a pretty bad spot if they have an injury there, plus that constellation of symptoms.
Yeah, yeah. And also sometimes for junctional bleeds where they have a part of the carotid has got damage and the bleeding is so excessive that your junctional bandages is unable to control it. They've started using something like TheraBands, the elastic bands, and the pressure that generates is phenomenal. It is incredible to use that as a junctional dressing because it generates much, much more pressure than our normal 6-inch elastic bandages.
And this is probably obvious, but I feel I would be remiss if I didn't mention it, especially with embedded objects, which I have seen a number of, pencils, various metal objects embedded into the neck that are bouncing in time with somebody's pulse. Don't take it out. Just wrap it, leave it alone, and wait for us to do it in an operating room. Yes.
That would be scary
I
to
always,
see.
yeah, you see it bouncing up and down. You're like, yep, we're going to go to the operating room and take that out. If you're not sure where it is, you can leave it, gently wrap it, secure it, and then we'll mess with it.
And similar thing with Foley's catheters in the neck is like, don't take them out. Let them get into the operating theater before you think of taking them out, because the bleeding will
Yes.
start immediately afterwards. And then even if you're in the operating theater, if you're taking it out, take the fluid out, let it remain there, check if there's no bleeding, and then gradually take it out. The same thing with pressure packs also.
Now with this hemorrhage control, as far as taking the airway, like that's a pretty big decision for a young medic to make, and generally they kind of hesitate and they look at the patient to kind of guide, like, should I do this or not? Does he need to? When you have like a bad facial bleed, they're bleeding into the oral pharynx. That's airway risk. You have bleeding into the neck. You have pressure on the neck, like you mentioned, and the other podcast I did on just neck trauma, trauma surgeon was saying that pressure puts a venous constricting band essentially on the inside of their neck vessels, and that'll cause the inner lining of their trachea to become congested and actually start to close off their airway from just the pressure, right? So, when it comes to, facial or even neck trauma, like how quick on that trigger are you to do like a definitive airway, either intubate or crike?
I would say that I would say that you should be much more scared of neck trauma than facial as an initial thought, because all the things we talked about, that could be expanding and there's bleeding in there. Some of the things you mentioned, I've certainly been in situations where the trachea and the internal airway is a centimeter plus off of midline, and then you're trying to cut through, and I've done it through infections and other places, and you can't palpate and you don't know where it is. So I would say if you're on the fence about it, like most things, do it. Conversely, in the face, I would say don't be as quick, be ready, mark out your landmarks, maybe infiltrate with local. But I've had plenty of patients whose entire faces are blown open or off, and they're leaning forward, they're able to nod, supporting their airway draining, and making sure you can take it in a controlled environment with more help, which, in the environment, you're describing, Burjor, is time and really difficult. But if you can maximize all the settings before you do it, that would be ideal. Because a lot of times, if they just lean forward, they can control their secretions, allowing you to prep and do everything or get ready to intubate. But I think it can be really scary if you haven't dealt with some major facial injuries, and then you have the pucker factor. And so I never fault anybody for taking an airway or doing a surgical one in the field, because, you rather err on the side of caution. We can reverse and fix a crike. We can convert it to a trach within 48 hours, and that patient can, is usually just fine. Minor complications from it usually. But I think it's such a hard decision to make. I don't know. What do you guys think?
So, I mean, what I see a lot is, when I'm me personally, I like to err on the side of caution. Like all this blood, if it's not coming out, it's going down. And if he vomits and then aspirates, that's a bad day. So I lean towards just take the airway. And as a counter argument, usually I'll get, well, I saw a guy who started a shotgun and, here's the picture. And, he maintained his own airway. He leaned forward and just drained. What they generally don't see is behind that guy is you'll see like this little shoulder with scrubs on and maybe an arm and airway tray right behind him. And I was like, you know who that guy is? That's an anesthesiologist. And if this guy blinks wrong, they're taking his airway. So I think I don't know how comfortable I am just trusting that this guy, and obviously every situation is dependent and nuanced, right? But me personally, like I'm quick to just take the airway. Once you have it, like it's now secure and we can manage it. It's a little harder on the narcotics, but I would take that any day over having to do an emergent cric because the guy just stopped.
I think another problem with facial trauma, unfortunately, and I wish that it was practiced, is that it's very hard to put them lying down. So doing a sitting cric is, I've seen my consultant do it in a field in India, and that's traumatized me for life. It is incredibly hard. Plus, because they're straining, the blood vessels in the neck are further dilated and they bleed a lot more. So the vision is affected. But you have that on one side, and the other side is that the airway could get compromised really fast. And I think that is probably more important. So obviously, but it's a technique which would be wise to be practiced on doing a sitting cric rather than a supine cric to a certain extent. And also some of the advantages of a facial trauma, especially when you have sometimes when you have a high velocity fragment hitting your face, it does is it cleaves the mandible or the lower jaw off. So it basically does not shatter it, it just slices it off, leaving a large portion of the soft tissue intact. Basically, it's pulled that mandible off, that section of mandible off, and the soft tissues which are stuck to it are torn at the point of weaknesses, which is next to the genial tubercles or next to the hyoid. So your tongue is very much intact, lower jaw is blown off, and then you can actually see quite clearly to intubate or put a cuff tube inside. But of course, then you have to have all the medicaments and to follow up on that stuff also. So sometimes it might be quite easy to do an intubation in these patients and harder in these patients to do a surgical one. So that's why you might have to balance both that off to a certain extent. What do you think?
Yeah, that's a good point. A lot of times in severe facial trauma, it looks horrendous, but they're actually fairly easy intubations. You see the blood in the back of the bubbles. If you have the ability to suction real good, and then somehow, and I think we were, talking about this before, control the tongue, you can throw a stitch through it. You can grab it with a hemostat, just get aggressive, yank that damn thing forward. And then usually you have a really good vision, especially if there's fractures, because you have, a great view. So a lot of times it's even easier than you think in some of those severe facial injuries. You just look straight down and boom, grade 1 view, see the cords and do the tube, and then everybody feels a lot better. But I agree, Dennis. Yeah, if you're not sure, and I'm thinking about me in the hospital, like ready to go right there, then we're much more comfortable sitting on them and okay, give it a minute, we'll get ready. But yeah, if you're in a field and you got multiple people, you got battlefield concerns, yeah, just do it when you can, and on the front end, because like you said, it's much better to have it than to start to deal with it in an immersion situation. Gosh.
Yeah. Speaking of the tongue, what about like tongue bleeds? Like we always think about facial injuries, you think about like the external, those things actually travel 3-dimensionally through their head. So the tongue can get hit, and I know that it bleeds a lot. So, how do you handle, lingual bleeds?
Basically, that's really, really a good question. And so we got like the protocol which said like for tongue bleeds, the horizontal mattress suture is what is recommended, and you use a handheld zero needle, which is a whopping big needle, and put hand ties through that. So we actually did do it organically to see whether it would work. And it posed some really challenging bits. So first of all, if the tongue is cut, that means let's say the anterior third of the tongue is cut. So you have posterior 2/3 flopping around inside. So you have to pull it forwards. Then you have the blood vessels, which are on the bottom surface of the tongue. So if you have a blood vessels in the bottom surface of the tongue and you're putting this whopping big needle through, you want to try to make sure that you don't prang any more blood vessels when you're putting it through, or at least try. So generally, anterior most bit of the tongue, stick in the midline, push it through. You can avoid it, grab it, and hold it. But if you're going to put a horizontal mattress suture through, that means you've got to push it in from the bottom surface of the tongue, pull it out from the top surface of the tongue, and put another one in from the top surface of the tongue, push it down through the bottom surface of the tongue, which has the danger of going through the blood vessels, as well as a zero needle is huge. It goes just straight into the floor of the mouth rather than being able to curve it back out, because those are the handheld needles they carry. So we've been trying to teach them how to do the figure of 8 sutures, which you push it in from the bottom surface of the tongue, take it out from the top, then again go through the bottom surface of the tongue, take it out from the top, and then tie it off like a figure of 8. So yes, they understood it, but it's like knee-jerk response when when you're faced with an enormous problem like that. You go to the thing which you know and done it before. So they automatically go straight to horizontal mattress, or they go to just traction and pull it forwards, or multiple interrupted. But the difference is they're not using zero numbers. They're using needle holder held suturing needle, which is a big one, but not zero one. And it is possible for them in that case to do it. So I said, at the end of the day, it's a physics. Whatever suture you put, and you get a good deep bite and compress that area reasonably and pinch that area reasonably with the soft tissues, and you have a traction suture also in place to grip it and pull it forwards. It's a physics. If you achieve that, we don't care how you did it as long as you achieved it. Andrew, you?
Yeah. Honestly, I would say even simpler. The takeaway is a bunch of stitches are your best friend. We do a lot of biopsies in the tongue, and because it's a big muscle, it bleeds like stink. But as soon as you put a couple stitches in and throw them, usually it stops bleeding. But with the tongue being a muscle, a lot of times those sutures will get loose and come out. But just start throwing a bunch of stitches, and then once you get some control of it, it'll usually stop dramatically. And like he mentioned, the floor of the mouth underneath it is kind of a different ballgame. You have ducts from the sublingual and submandibular glands, the lingual nerve, some important structures. So if it's deeper down under there, I would say pressure, you can get bidirectional, kind of outside, inside, but be a little bit more reticent to just start throwing stitches down there, because you could really, depending on the injury, obviously, if you're trying to get hemorrhage control, whatever. But there's much more important things there, where the tongue is like a big ass piece of muscle. I had a gunshot wound a few months ago where it hit the mandible, exploded an entire side, and then lodged some chunks of bullets as well as a few teeth deep inside the tongue too. Depending on where the mechanism hits, you can also have stuff in there. You don't have to worry about pulling them out in the short term. Again, just stitch over things and try to compress it. But stitches really help. And I would use something, as big as you have, and as well as don't use resorbable. Just like, put a big 200 silk nylon, whatever you have, to try to give some stability to the region there.
I'd agree with Andrew. Keep it simple. Like I'm probably going to back out with this figure of 8 thing, because keep it simple, just normal, simple, deep sutures. I think, yeah, but absolutely, Andrew, you hit the nail on the head there. Yeah.
And pursuant to kind of all this stuff too, thinking about using our local with epi as a means of damage control evaluation is not a bad idea, right? You have a tongue that's bleeding a ton. You shoot 2 to 4 cc's of whatever you have with hopefully 1 to 100,000 epinephrine in there. You can slow the bleeding down often enough to then help control it further. So we know it's not a long-term solution when that epi wears off, and that vasoconstrictive effect in the head and neck, I think about lasting for about 90 minutes or so. But a lot of times it'll give you the ability to better evaluate whatever wound. So, sometimes I think we focus on this is not a good hemostatic agent. Well, when I'm dealing with bad bleeds, sometimes I'll squirt it all over the place, getting some vasoconstrictive effect from the epinephrine to better evaluate and then deal with things. So don't forget we have that tool as well to use for that purpose.
Yeah. And then what I used to do long time back was grab it with a towel clip. We had those really sharp, gorgeous towel clips. Grab it with that, and when you yank it forward, the residual tongue, especially in biopsies in the good old days, when you yank it, the tongue, pull the tongue as much as you can forward. What happens is that the back part of the tongue gets compressed with the existing muscles in the floor of the mouth to a certain extent, which pinches it to a certain extent, which reduces bleeding marginally, which also helps to a certain extent.
So, March things, as far as T-TRIC March, initial contact with the patient, is there anything else that we want to put out?
I think for R is also respiration or so basically you get an airway, but if they have post-blast lung injury, you still haven't got over the dangerous bit of it and can catch you a bit unawares. So you start relaxing once you got a surgical airway in place, control the bleeding, but that comes like a bit more downstream and that can catch you out.
Yeah, like your work just started. Like you got 2 out of 5 things done. So, yeah, your work is far from over. But what I was starting to think about is like, okay, long term, we've gotten hemorrhage control. You know, you're in a ditch and you plan on being there for the next 2 to 12 freaking hours before you can finally get out of there under cover of darkness, hopefully. The mouth is really freaking dirty. Like infection, wound management, like how do we handle this?
Yeah, I think I want to touch on just a couple of, not exactly in the immediate, like, Marsh driver that we're talking about, but a few of the other kind of more emergent things that I at least want to acknowledge in like my world. Yeah. And that would also involve the procedures of a lateral canthotomy inferior cantholysis for orbital compartment syndrome. And being aware that with mid-face injuries and dealing with that is a skill that it's something that I think we talk about but rarely train on. I try to do it every time we have cadaver trainings for folks. There is an alternate technique too called a vertical lid split. Some emergency medicine friends of mine and I are publishing a paper on this soon. And then probably going to publish a technique paper as an alternate method that's actually shown a little bit better results in predictability on cadaver studies so far. And I had an emergency medicine friend who used this, but training that, because if that happens, you need to address it pretty quickly. Because otherwise there's not too many emergencies outside of bleeding and airway in the head and neck. A lot of stuff we'll treat secondarily. But kind of like Burjor mentioned, jaw stabilization techniques for the mandible fractures are a really good thing. We can dive into a little bit more. In terms of just what you mentioned, because the head and neck is so vascular, infections really aren't an acute concern in, say, like an 18 to 48 hour period. The best, keeping things clean is great. Just irrigating things out if you have a moment and you have saline. I really wouldn't use water due to the hemolysis effect. If you have to, yes, but just rinsing things out. And then, if I think about it a little bit more in okay, we're sitting on this patient for potentially days. It sounds stupid, but just brushing the teeth, Perdex or chlorhexidine if you have access, to try to keep things clean, and definitely antibiotics. Penicillins are kind of our first line and most effective if you have the ability to get those in. I know our medics commonly carry carbapenems like ertapenem, totally fine, or meropenem. Those has a great spectrum against oral bacteria that would be in different wounds. But second line for me is these days usually doxycycline because of a very high resistance that's pretty much across the country with clindamycin. But thinking especially, there's a fallacy that you guys probably don't understand this, but I've heard even emergency room doctors say that bullet wounds are sterile because of the heat generated from the round. Not true at all. They're incredibly dirty. Most shrapnel pieces and bullet chunks end up abscessing and pussing out, and I'm sure you've had the experience, Burjor. A lot of times, years later, I'm taking these patients back to surgery to go dig out abscess chunks of stuff. So very, very dirty injuries. Do everything you can to try to rinse them out and keep them relatively clean. I think another big point in terms of, okay, we're moving forward in time a little bit. If you have open injuries, exposed injuries, just generally try to keep some damp stuff on it. Some damp gauze and covering things is great. a lot of times in the hospital, we'll change out big open infections or problems, what we call wet to dries, right? You just put wet stuff on there, let it dry, take it off. And because the head and neck is so vascular, a lot of times that'll start to build a granulation tissue bed. So just keeping some damp stuff on it to protect it is a very, very reasonable thing to do. Or even if you have a little bit more comfort and they're, I've certainly done this where they're missing whole lips or chunks of face, and you have something like xeroform gauze, which is iodoform impregnated, you could throw a couple stitches to just generally hold something in the gap, bolstering something in there. It doesn't have to be perfect. It doesn't have to be elegant, but just kind of gently holding kind of some dressing in there so that, you don't have to worry too much about things moving as you're moving the patient, potentially doing other things. Completely fine. We're going to take it all down, clean it the heck out once we get them to an operating room anyway. So I think that's another very valid thing to at least consider based on your skill set.
Because when I'm, at least in my thought, so, initial, we're packing, and then I'm going to secure that with probably like a Bartland dressing or something like that. And once you get everything secure and everybody starts calming down because we've moved away from the threat, it's easy to kind of forget and just like leave that in place. It's working, like don't address that. And those wounds are still dirty. Those wounds have been exposed, etc. So I guess when would you even consider taking off this dressing, opening things up, starting to clean the patient, clean the injuries? Like we'll use just drinking water. Like if it's clean enough to drink, so we're not talking like sterile water where I would necessarily be worried about lysis of RBCs or anything, but just if it's clean drinking water, clean it off, bare minimum soap and water, clean the skin off, and then start thinking about wound management. I guess when would you guys even consider doing something like that? 24 hours?
Can I jump in? So basically, let's start with the irrigation. So you're stuck for, let's say, 12 hours, R1 area, even R2. If you start at the scalp, if the scalp is like sort of peeled off to a certain extent, and yes, if you got time, you can clean it, pop it back, and maybe put a few stay stitches in. The thing to be careful about is not to put stitches under tension. So that is not. But also not, this is what I did in the past and I suffered for it, not to put loose stitches because they don't do anything. They just break down later on. So not to put on the tension, to put reasonably good stitches. And if you can see the firm layer, which is the aponeurosis of the scalp, which is the tight leathery layer, then yes, put a deep stitch there and a skin stitch on top. But if you can't see that, then do it as a single layer rather than multiple layers, because otherwise they tend to get infected. Now, if you cannot pull it down if it is under tension, then like Andrew says, put an iodoform dressing on top, put a dressing on top and hold it in place. So do not stitch it under tension. Then you come to the eyes. Now, the problem with the eyes is that the eyelids and the area around the eye is loose tissues. So if it's blast, the initial blast wave tightens the skin because it's pulled back. Then comes a blast wind with the sharp debris. So it's tight, and then you have a sharp debris, which just goes through and like shreds that whole place up to a certain extent. So you do have problems about the eyelids and the area around the eye. Also, if it's not that bad, a single burnt eyelash can cause a lot of irritation. So do you irrigate these patients' eyes or not? Now, the general consensus is not to irrigate because very often the debris which has gone in could have perforated the front of the eye and caused an open eye injury. So it's incredibly painful. But it's still advised not to irrigate. But you can put chloramphenicol ointment or lubricating ointment inside it. But what's going to happen is that this area is going to be severely edematous fairly soon. So now is the time, right at the start, to get a good baseline visual acuity readings, because later on it's going to get harder and harder to get that. Then you come to the cheek and the skins. Of course, you need to clean it because there's metallization. All that dark stuff is on the face. You got to clean that off. But the problem with these patients is that they very often will have a rupture in their ear. The tympanic membrane will be ruptured. There would be a lot of ear damage. So, what I suggest to our students is that put a Vaseline gauze, any gauze, in the ear before irrigating to make sure that the dirty water doesn't go into the ear because it'll cause you problems downstream. Then you come onto the nasal area. So the nasal area and the lip area where the blast goes through. Of course, if you're burning, charring, expect that you might have edema coming later on. Think about airway. But more than that, if they are just a suitable distance away, this area is going to get really, really dry. So think about moisturizing or putting some sort of a Vaseline in the area because the area gets, and once it gets dry, it cracks. So it adds another pain to the patient. And then even if it doesn't crack and it heals by fibrosis, the mouth tends to shrink a bit with the pain. And that's another problem which you could have avoided to a certain extent. Um, and yeah, and I love the bit about iodoform gauze because Andrew, that was a question which I written down. What sort of packing would you use? And I loved it that you said iodoform gauze and damp gauze. It's such a brilliant, brilliant point is to put damp gauze. When do you change it after putting it? Andrew, I put that question back to you.
I think the easiest way to think about it is when it dries out twice a day. But yeah, you don't need to make it more complicated. If you recheck it and it's dry, you'll peel it off. There'll be a layer of gras and junk with it. Okay, then you put a new damp layer on. So about 2 times a day. But really depends. You can redamp it a little bit too. But
Lovely.
yeah,
And the other thing what we try to tell them is like if they're hit by a exploding rifle bullet or shrapnel and you have bundles of foreign debris scattered around, is not to dig around trying to get it out. Just put a dressing on it, cover it up, and let it be. And we do like that elastonet dressings, which burns patients use. It's like a tube with a netted tube. And it's lovely to hold dressings on in fiddly areas. We, of course, teach them how to do barrel bandage dressings using just a normal elastic gauze, an Israeli or an Elias gauze, any of these, and they learn how to do barrel dressings to dress things like perforated cheek lacerations. So if you have a perforated cheek laceration, it's very hard to put pressure to control the bleeding because it's through and through. So what we suggest is that you put a piece of dressing inside between the teeth and the cut cheek, a Celox dressing in the cut cheek itself, a third one on top, 1.5 to 2 inches extending on top with pressure, and hold it all together with a barrel bandage. And that sort of dresses the cut cheek. And the patient can actually drink fluids and all by tilting the head to the opposite side and letting gravity do the work. The only changes I do for that is that the first dressing you put, which is between the teeth and the cut cheek, tell them to wrap it up in cling or plastic so that doesn't get very wet inside the mouth. So that's the first one, second one, and the third one. That seems to work really well for these patients. And also don't forget that if you're stuck with a patient for 12 to 24 to 48 hours, the bones need to be at least supported. And therefore comes to my main question at the start of this podcast is to know the basics of jaw wiring. Even the basics of jaw wiring, you don't have to rigidly reduce and fix it. You just want to support it. And thereby a simple bridle wire, it's just one wire which goes around the teeth, is enough to sometimes support a fractured jaw. Or if not, you can put eyelet wiring and just stabilize the fractured jaw. But if the patient goes in R2 stage where they are stuck for even a longer period of time, then we come to the more complicated ways of support, which we are teaching them now, which is using external pin fixation or a K-wire or something like that to have more support because they've got missing tissue. They've got missing bone, missing soft tissue, and you want to support the residual bone because if you don't support the residual bone, then the muscles which are attached to the residual bone is not supported. And that will affect the function of the patient. It'll affect his swallowing, it'll affect his breathing, it'll increase the chance of infection, increase the chance of secondary bleeding, and actually putting external pin fixation to just support these broken bits into this approximately normal place. It's very easy to do external pin fixation. The problem lies nursing after putting the external pin fixation. And hopefully he's transferred from there by that time. So that is the main thing about it.
And Dennis, to cycle back to your kind of original query, I would say, when do you take this down and do what we're talking about for all these steps and more thorough thing? Probably it's not urgent. Sometime in the first 24 hours. Once you've really stabilized things, people are not in emergencies, you can gather your supplies. And, as a surgeon, one of the mantras that I teach my residents is surgery is about vision and access. If you can get to it and see it, you're probably going to have a good time. If not, you're going to have. So having somebody else hold a flashlight, or the patient, they tend to be such deep, dark holes in the mouth, especially if you're not comfortable with the tongue moving around. So once you can really optimize your conditions, then kind of go through it. And one of the points that at least I kind of theorize, if I put myself in more medic shoes, you could be worried about dealing with these complicated injuries and like selecting like, how do I suture and things. Just give it a shot. Even if it's a couple stitches generally holding tissue in roughly the right place, I'm going to take them all out anyway and redo the whole thing. So like, don't stress it. Just do what you can. Throw some stitches in there. It's fine. Nothing you do is permanent. So I'd rather you do something than be scared to do anything in terms of some of that basic kind of wound management things.
Andrew, briefly, what is vertical lid split?
Yeah, vertical lid split, for the listeners, if you can picture looking at an eyelid and you go about 2/3 of the way lateral, a vertical lid split is simply a full cut through the eyelid. You can do it on the upper lid, lower lid, or both. So we can accomplish the same objective as a lateral canthotomy inferior cantholysis, which is detachment of the lower lid to allow the eyeball more space to come forward, relieving the pressure transiently on the optic nerve, which can lead to blindness. The lid splits sometimes in severe swelling, trauma, tissue distortion. They have what's the fail rate? There's some great literature, and I recently went through all this because of the papers I'm working on. Studies in the UK showing that maybe 70% of ER doctors are comfortable even trying it. And then, forget about tissue distortion in bad areas. The success rates are not that great. I mean, they're reasonably high, but it's not anywhere close to 100%. We're talking like in the 70s, 80s. So the lid split, a lot of times you can see where the eyelid is. It's even in bad things, you can just lift it up with a little instrument, take a scissor, and then make a 5 to 8 millimeter cut up. And then you can do the same in the lower, and it allows things to come forward. And us or any oculoplastic surgeon can repair that within 7 days and be totally normal. So it's really cool. I hadn't really been aware of it, but it recently came into my, awareness. But we're thinking of publishing a technique paper in the Journal of Special Operations on it for some increased visibility, because I think it's even easier than a lateral canthotomy inferior cantholysis, which can be tricky. So having it as an alternate method, or if a lateral canthotomy fails, then you can do it. I think it would be a great thing to train all the people that we're talking about, in that forward medicine environment.
Wow, that's so interesting. Yeah.
I know. I thought so
Oh,
too. I was
wow.
like, "What? This is crazy." Yeah, great.
So I guess for this lateral lid split, what is the success rate compared to a lateral canthotomy? Because it sounds way easier.
Yeah. There's the big paper on it so far was from a couple years ago by a few ophthalmologists. One of them is Julie Elpers. We brought her in on our paper for the case report, but there's very few, if any. I think the one that we wrote might be the first case report of this used on a person, but there's some cadaver work where they inflate the, around the eye and measure the pressures before and after, showing it as a chunk 5 to 10% higher success rate doing this than the lateral canthotomy on cadavers, at least. So yeah, if you Google Julie Elpers or vertical lid split, there's a few other names of it, but her and Roxana kind of pioneered it, and it's pretty recent. It's something that oculoplastic surgeons will do frequently, or like before they go take out an eye tumor or something to get better access. But then they started translating it to, okay, why wouldn't this be as effective for the same purposes as a lateral canthotomy? So yeah, it's pretty interesting. There's a MCrit podcast or short one or blog on it. So there's a few things that you can find on the internet about it, but if you actually look at papers, there's very little that has been published so far. So we're hoping to kind of at least establish a paradigm of technique. So because when I saw it, I was like, this is way easier than doing a lateral canthotomy where you tying in, tying out, you try to cut down, you're hunting for the guitar strings. Well, guess what? A lot of times you can't find the guitar strings and you just keep cutting and hoping until it works. I've been in that situation, a lot of people are. So hopefully you'll keep an eye out for it over the next year or so, because I think it'll be interesting.
Absolutely. Yeah. Yeah.
Awesome. Awesome. Well, guys, when it comes to facial trauma, like there's entire specialties for it. So we can't cover everything, but as far as the medics, what you would love for them to know, is there anything else that we need to cover?
Or can I ask Andrew a question? Is like, like when they reach you, let's say after post-blast injury, because the local region is so damaged, it's so prone to infection, blood flow is low. Have you tried putting titanium plates or something where large sections are missing? Or how do you do reconstruction? What is the uptake of reconstruction when you are putting them all back together? Does the health of the local area affect you doing microvascular surgery? How is it all?
Yeah, and I'm a big believer in whatever level of medical training people have. If they have exposure and experience to the next higher level or even a level above that, they can more effectively do their jobs. Um, so I think a key point before answering your question is for if you're in this field, just like we have an open door policy in my place. I bring special operations medics and PAs and docs over to us to do these. We cut the face apart routinely, several times a week. Cut the whole thing apart, move it, do all these cool things. Seeing it in a controlled setting will give you a point of reference when you're doing it in real life. So all it takes is a little bit of effort because almost everybody, I guarantee you, if you reach out and express some level of interest, they'll bring you into their world and let you do a bunch of stuff because at least in the military, we appreciate what the people have to live with and go through in our field. Understanding that when I look at defects, I think about it first as, am I just missing hard tissue, bone, soft tissue, or both? Because if the answer is both, like a big piece of the face is missing bone and tissue, I can't just fix the bone and I can't just fix the tissue. I pretty much have to start with a microvascular transfer. The workhorse of that is the fibula. We take a big chunk of the fibula in the leg and a long pedicle blood vessel, and we transplant that in addition to, usually planning from a point of rehabilitating their dentition and implants and everything. So if it's just hard tissue, a lot of times we'll put plates in or do other things. Soft tissue, we can do local regional flaps or sometimes transplant soft tissue. But if you think about what they're missing, and it's quite obvious of hard tissue, soft tissue, they're going to need a big reconstruction anyway. So they're gonna end up probably losing a little bit more. I think an important point is, especially with blast injuries and gunshots or high kinetic injuries, that secondary tissue wave and destruction really can happen over 3 to 5 days. So I'm a big fan of external fixators. I put them on all the time. Just rinse it out a bunch of times, let the tissue declare itself before coming up with a definitive reconstruction. And generally, we'll do that definitive reconstruction, the planning and everything, usually somewhere in the 6 to 8 weeks marks afterwards. So a lot of times we'll temporarily stabilize things if it's a more complicated recon, or as Burjor, we'll go in there and just fix it all right away if it's more low velocity air caliber, more minor in terms of plating things back together. But reach out to the people around you because I guarantee you they're going to want to welcome you in their world. And this is such a reality. And what the current conflicts are showing us, like if you're in the military, you're probably going to have to deal with this at some point, right? The literature over the entire GWAT war is about 25 to 33% of injuries involve the craniofacial skeleton. And the data coming out of Ukraine is, the sparse papers I've seen so far, but hearing from experiences and people living that reality, like we're talking about, substantially higher. So, I think this shifts facial trauma up to one of the key things that likely we'll have to deal with if we're in any sort of conflict that's similar to this. Do you guys think that's a relatively, acceptable thing when we're predicting future training and how we prepare for it?
Absolutely. And Dennis, one more. Can I ask one more question? Andrew, what news of mini ties? Because that's the first time I got in touch with Andrew. He had these round zip ties, which you do instead of jaw wiring to stabilize a fracture of the lower jaw. And it is like rounded zip ties with a system with a little needle which you push through. They're fantastic. But what's happening about that now?
Yeah. Briefly for our listeners, just jaw stabilization of the mandible. This doesn't work as well in the maxilla because it tends to be like fort fractures and floppy, although you can do sideways kind of things. But in general, when you have a broken jawbone and say the injury is not that bad, or, we're not talking, their big gunshot wound, everything. And even in those situations, by stabilizing the lower jaw together, it's kind of like putting a cast on a broken extremity. You reduce the pain, you maybe give them back function, to eat and drink a little bit until you can get them out. And in general, when we talk about this, the term that Burjor mentioned is a bridle wire, right? And you can get creative with this. You can do it with wires. And generally, if you can find where the break is, you want to pass a wire, not to the teeth right next to the injury, but a couple teeth on either side, and just kind of tighten it down. In general, two things will happen. One is if the break is usually straight up and down, the teeth will kind of come together and then it'll be relatively okay. If the fracture is oftentimes a shear, when you tighten it down, it's actually going to get much worse. So if that happens, you just take it off and you've given it a college try. Well, if you think about what could you do this with in the field, you can try to use almost anything you have. Zip ties are a little too big and thick, but I would say if that's all you got, give it a shot. Because the worst case, if it doesn't work well, you just cut it out and you're no worse off than you were. You can move those things and play around with them. Generally, it's nice to localize it and shoot it up a little bit for patient comfort. But about 7 years ago, this thing came out called mini ties, MINNE. And if you Google my last name, Genzer, Genzer, and mini ties, you'll see a bunch of publications. I happen to be kind of at the forefront of applying this technology in some of the reconstructions and surgeries I do. But when I first saw it, I immediately thought about the applicability to austere medicine and special forces medics, because all you need is a couple of these ties. They weigh almost nothing. There's no needles involved. It has a blunt introducer. You could throw it in your kit and bring it with you anywhere. And it's a one-way zip tie. You just pass it between a couple teeth and then tie it down and it stays locked in there. And you can use it to get MMF, maxillomandibular fixation. You can wire the jaws to each other. You can bridle wire with it. It's so easy to use. The first time I used it, it took me 3 to 4 minutes. And if you've ever tried to wire two jaws together, that can be really, really hard and take very specialized instrumentation. So this was like, let's make it super easy. I wrote a technique paper on that as well as in the Journal of Special Operations Medicine. You can see a bunch of pictures. You can Google it and look at it. They just came out. I use it all the time. I've used it, 4 or 5 times in the last few months for mandible fractures and surgery, for bridle wire techniques to send patients to the floor before I bring them to surgery the next day. But the next generation came out where now the ties have a version now that has a little hook on them. And this allows you to hook rubber bands or additional ties to the tie that you put on, which it's like it gives you a lot of flexibility in the field because you can just start, putting things back together or reasonably holding them in place. So it's a wonderful technique that I think really brings the jaw stabilization factors, which we're seeing now become so much more necessary, to the people at the front line. So check it out, because I think it is a true game changer, where before you're trying to figure it out with wires or, not really good products. But yeah, mini ties, they're amazing. And no disclosure, I don't have any stock in the company. I'm just a fan. And I think it's a really revolutionary step in this world to treat these kind of injuries.
And you can cut them with a scissor. No? You don't even need a wire cutter.
Any scissor.
Yeah, they're
Nope.
fantastic. Yeah. I haven't seen the hook ones though, but they're fantastic. Sounds good.
Well, awesome, guys. I really appreciate you guys jumping on.
Thanks, Dennis.
Pleasure. Yes.
Absolutely loved it. Pleasure as always.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.